Hello everyone, welcome back. My name is Cemal and I'll be chairing the session. We'll talk about the primary care in the UK, and we have two guest speakers from the UK. We have Ayede Ologun, who is a GP in Manchester at the moment. She is a local faculty member of the Royal College of GPs and also does clinical supervision, and she's an examiner in the OSCE examinations. And we have Ali Siddiqi, who is a trainee doctor. He is in the second year of his GP training, currently working in Brighton in Obs and Gynae hospital rotation. I hope that's treating you well. And they will share with us, in general, the primary care structure in the UK, how it works, how the training works, what do we use for monitoring our progress. And at the end, we will have a little panel discussion involving Professor Akpınar as well, to talk a little bit about how we can make international collaboration and basically the importance of being the networking and reaching out to different countries. So thank you very much for joining us, and we'll start with Ayede. Have fun.
Thank you. So I'm sharing now. Thank you. Good morning, everyone. I'm so happy and honored to be here. I would have loved to meet everyone in person, but that's not possible due to coronavirus. So thank you to the wonderful speakers that have spoken so far, especially Dr. Cemal on leadership talk. That was really inspiring. I'm Dr. Ayede Ologun. I'm GP in Manchester, England. I will be talking on the primary care structure in the United Kingdom. It's difficult to be interactive, but feel free to pop your questions if you have any, and if time permits, I would be able to take questions afterwards. So I wear silver hat at the moment. Just a little bit about me. I'm GP in Manchester. I'm a member of the Royal College of General Practitioners Junior International Committee, which is our on this conference. I'm a member of the Northwest Faculty Board. I'm a BM network person. I'm a clinical supervisor. I've been a GP over 5 years, so that's right. I do a lot of stuff at the moment. I'm also an OSCE examiner for the University of Manchester and Liverpool third and fourth year medical students. I'm a General Secretary for Black Women in Health Network in the UK. And so I'm happy to be here. So my topic today is the primary care structure in the United Kingdom. So primary care services provide the first point of contact in the UK. So it's like a front door for the NHS. Primary care includes several services, which can be GP surgeries, community pharmacy, dental, optometry, and other services included. So government, we can't discuss primary care without discussing what the NHS is, because this is where the funding from primary care comes in the UK. So government funds medical and healthcare services in the UK. The NHS provides the care free at the point of entry, and this care is delivered by several organizations under the NHS. And all these resources do require maintenance, development, and management for it to keep providing these beautiful services. These organizations that are under the NHS include the Department of Health, NHS England, Clinical Commissioning Boards, and NHS Foundation Trust, which directly fund hospitals, ambulance services, social care, and primary care services. So this is just a diagram of the flow, and this also explains the flow of money through the system. So we've got the Department of Health, which leads everything, goes down to NHS England, that control the Clinical Commissioning Board. So every area, town, and city that provides services for patients do have clinical commissioning boards that source out services and funding to GP practice, primary care, ambulance care practices, NHS hospitals, mental health services, and also the community services like district nurses, social services, and social health care. So the focus today will be on the UK primary care service, okay? So the UK is known around the world for the quality of its primary care. It's the world's largest healthcare system with the most developed primary care service, according to me, and it produces the best health outcomes for all citizens at good value. Access to all is the tenants of the NHS, general practitioner is usually the first person people assess in the NHS. So you don't go to see specialists quite directly. You have to go through, most times, through your GP, except you're going privately. So that's good. General practice I would describe as the bedrock of the NHS, because general practice provides over 300 patients consultations in a year. Yeah, that's compared to 23 million in A&E. So if general practice fails, the NHS will fail, because we see over 1 million patients in a day. Over the past decade, primary care has transformed to something that is internationally leading, and this is to help improve accessibility, patient outcomes, and sustainability for the patients we serve. So this is the structure of the NHS, of the primary care services in the UK at the moment. The primary care is usually, and with the formation of what we call primary care networks, this structure really explains everything, which I'll explain in a few minutes. General practice, GPs are usually at the leadership point or the head point of this structure of primary care. So GPs work in different settings like out of hours, GP surgeries, walk-in services, urgent care centers, A&E, other community services like nursing home, hospice, and we have other allied professionals that work within the primary care healthcare systems, and these are nurses, physician assistants, paramedics, so many services within the NHS. This list is not exhaustive. So we have district nurses, we have so many services that work hand in hand with general practice, with GPs, to provide the excellent services we give our patients. The key improvements in primary care structure. These are key improvements that have happened over the last few years and are still happening now. So there's been the government's objective to boost GP numbers. That has been a little bit on hold due to the COVID-19 pandemic. There's been extended access to GP appointments for patients to see their GPs in the evenings up to 8 p.m. on weekends, on Saturdays, and some surgeries used to hold on Sundays. That has been a little bit reduced because of COVID-19, but those services are coming back into play. And there's been more convenient access to GP services for patients over the last few years. And patients are able to book their appointments online, check their medical records, check their blood test results, see a lot of stuff. And with our digital innovation had to move exponentially due to the COVID-19. There are now new services, new web services and hubs like eConsult, Ask My GP, Footfall, where patients can go and ask questions to their GP services, get simple things done rather than having to see their GP in person. Over the years, there's been an expansion of multidisciplinary primary care, which is the primary care networks. The primary care networks are just a network that have been able to provide better funding and structure for patients in any area. So different GP practices come together and serve over 30 to 50,000 patients, and they're able to provide personalized services like in-house counseling, musculoskeletal services for their patients. So it's been really good, and this came into play in January 2019. There's been a little bit of changes happening within the network at the moment. Over the years, there has also been modernization of primary care premises, and with the talk about leadership and digital innovation, we all know how that has been technological improvements over this last few months in use of artificial intelligence, telehealth, and we're using a lot of video consultations now. When I did this presentation, it was in March before the crisis, and I wrote flexibility and dealing with national crisis, which is what I see as what primary care services, primary care has been able to do with the changes that have happened over this many years, funding and budget cuts. Primary care has always been flexible and able to mold into a service that still provides good patient safety and good care for all our patients, high quality care, I would say. So I've just put this a little bit about general practice and the COVID-19, where we found ourselves in the last few months and where we are now. So obviously we will all agree that the COVID-19 was the greatest public health challenge we've ever faced, especially for general practice, where we see 1 million patients a day, because we had to close down. But GP services opened throughout the pandemic. We were able to continue providing high quality care throughout. Even if we were locked down, we're able to still provide telephone consultations and also still bring patients in if we need to see them. I worked throughout the pandemic from March till now. I know I worked today, thank God. I worked throughout the pandemic and I saw 1 or 2 patients almost every day. So things that we can't escape. We're still diagnosing breast cancers, oral cancers. We're still referring people for heart attacks. This stuff was still happening despite COVID being in the building. So we had to still continue to provide this high quality service throughout the pandemic. There has been an evolution. I mean, general practice has had to evolve exponentially in this short period with technological and digital innovations. And GPs are operating remotely. But like I said, we've always had the opportunity to bring in our patients. And going forward, post-pandemic and now, there is continued improvements in the primary care structure, even with the new way of working, advancements and perfecting of these innovations that we've had to embrace in terms of telephone, video, easy access for patients, patients delivering feedback. Although they have caveats to these technological innovations for certain groups of patients that can't really use the services, but it has been quite substantial and remarkable how much it's helped a lot of patients, and obviously through the pandemic. Patients can have video consultations now from anywhere in England. I consulted a patient in Italy. He had traveled there for just as the lockdown in England was over, but he couldn't come back because there was just 1 or 2 flights back from Italy to England. So, and he needed a letter for his place of work. So I was able to do that letter by having a video consultation with him from my office in Manchester to him where he was in Italy, which is a very beautiful place. And I was able to email his sick notes and stuff to him. So the digital innovations has helped promote a lot of stuff post-pandemic and now. There is ongoing and will continue to be ongoing engagement with the Royal College of GPs and NHS England to keep providing this high quality of services that we want to keep giving our patients. So thank you for listening.
Hello again, everyone, and I'd like to thank Ayede for a very succinct summary of the role of the primary care. And as she said, it's the national religion of Britain, NHS, and a unique structure that allows all the health services to work on. What an amazing statistic to say 90% of all interactions within the NHS happens through primary care, and the secondary care only takes the remaining 10%, and this is done by only 12% of the total healthcare budget given to primary care. So thank you very much for sharing your insights. And now we have Dr. Ali Siddiqi, who is a GP trainee in his 2nd year in Brighton, and he will tell us a little more about the training processes, hopefully some of the exams that you're going to go through or you might have gone through, and the nightmare that we all call e-portfolio and how those processes work. Thank you very much, Ali. We are all looking forward to listening to you.
Thank you. Hello, hi. Thank you again to my colleagues for their wonderful talks this morning. My name's Dr. Ali Siddiqi, and I'm a GP trainee in the United Kingdom in my 2nd year. And today what I'm going to do is talk to you about the GP training, what it's like as a trainee in the UK, and the e-portfolio, and what we have to do here to fulfill our requirements. So this is just a very basic, just start from scratch, because medical training is very different everywhere in the world. But in the UK, you spend around 5 to 6 years in medical school, and then once you qualify, you're provisionally registered as a doctor. You then spend 2 years in what's called foundation training, where you rotate around different hospital specialties, as well as general practice, if you get allocated that job. And then at the end of that 2nd year, you're fully registered as a medical practitioner. And that is when you decide what training you wish to do. So you could go into GP specialist training, or you could go into any other specialist training, obs and gynae, pediatrics, radiology, and whatever you like. So that's sort of the cycle that we work to in the UK. So very briefly, what I'll talk to you about is just entry into GP training here in the UK. It's quite a simple process. It's an online application form via the portal Oriel. And what you do is you fill in just about your past medical experience, where you've worked before, any time out of training, your qualifications, and then a little bit about why you want to do general practice. You then, basically the entire country is split up into different regions, maybe like 50 or so regions. In fact, there might be more actually now, and you rank where you'd like to work. This thing I've written about targeted enhancement is in certain areas there are not enough GPs, and these are often more rural areas, and what the government does is it actually pays you to go and train and work there, and can up to £20,000 sterling to go there. So once you've ranked your places in the application form, you can rank as many and as few as you like. So you can only rank, if you want to just work in London, you can only rank the 20 or so places in London. If you want to work outside of London, you can rank the entire country. You then sit what's called the MS RA, which is basically exam, and the breakdown is there. It's quite a long computer-based assessment. Half of it's clinical problem solving based on just clinical knowledge you've gained as working as a doctor, and the other half is professional dilemmas. So what that is you're given a scenario, and you have to rank in order of, you might be a doctor on call and you're given a scenario that you're to deal with, and there's 5 options, so lots of different things going on at once, 2 medical emergencies, and you rank what you think is the order of priority. It can obviously be difficult. That's probably quite a difficult part of the exam. And what happens is then the top 20% of candidates would get straight into the next round, and the remaining 80% would go for an interview where you go to a regional centre and you do an OSCE style scenario, so role play with actors, and are assessed. This might be suspended this year due to COVID. It's still changing, so the latest up-to-date information will be on the website I've listed down there. So GP training in the UK is 3 years full-time, or the equivalent part-time, so you can go to 80% or 60% or even 50%. So obviously that would extend your training by a number of years. It's actually the shortest training program in the UK. Obs and gynae 6 years, radiology is up to 7 years. So it seems, it's funny that as a general practitioner, you have to know the most almost, but you have the least amount of time to train. You spend up to 18 months in hospital posts, and then another 18 months in a training practice throughout your time, or this varies wherever you're training. So the hospital specialty posts are listed here. So pediatrics, obs and gynae, orthopedics, psychiatry, general medicine. And you normally do 2 years of hospital rotations, 4 months each. And then in the final year, you're allocated to a GP surgery with an allocated trainer who's responsible for your training. Now, some of these are compulsory, so pediatrics is compulsory and psychiatry is compulsory. And then you can also pick others that you wish to do depending on the area you work, the region in the country you work. So obs and gynae is what I'm currently doing. I'll then do genitourinary medicine and then pediatrics this year. Last year I did emergency medicine and general practice and elderly care. So obviously the Royal College has a curriculum for GPs. It obviously covers, most of medicine, but they break in 5 capability areas. It's basically about managing long-term care, caring for the community, so public health interventions, being able to relate to your patients, and then applying this knowledge and working within a system, as my colleague discussed with the NHS and how that's all structured. So the portfolio, you either love it or hate it, but you have to do this. It's every trainee is assigned an educational supervisor who's responsible for their training. So I have one who's responsible for my training every 3 years. And then this is an online assessment tool, and you have to complete certain competencies during your placements to get signed off. So these can be reflective logs, case-based discussions, patient survey questionnaires, feedback from your colleagues anonymously, procedures that you might have done. And then at the end of every year, it goes to a panel, and they see if you've competently, submitted enough information, and you're allowed to go on to the next stage of training. So I'll just go through some examples. This is my portfolio. It's very recently moved over to a new platform the last week, which is why it's looking quite empty. But you basically have to do a certain amount of learning logs. So clinical case reviews, cases you might have seen, or anything that's happened that's, provoked a response and you reflect on. You also do leadership projects, audits and quality improvement, academic activities, and you link these to a certain curriculum. So these clinical case reviews are probably the most important and the ones that people probably struggle with the most. You have to do 36, and they have to be reflective. And you can see that you pick an area of the curriculum. So mental health, urgent unscheduled care, population health, and then you pick a skill, so diagnostic skill, communication, or anything else that's listed, and then you reflect on what you've done, how you'll sort of improve it, and where you'll go to find your knowledge to improve it. And your supervisor sees all of this and makes sure that you're meeting all of the requirements of the curriculum. You also have educational assessment. So these are sort of CBDs, case-based discussions, where you see a case in hospital and you write it up. You have mini cases, so directly observed consultations, where someone will watch you interact with the patient and then feedback on what you did well, what you didn't do so well. Did you manage the patient adequately? What more could you have done? And that's a good sort of learning tool. You also have a clinical supervisor report. So in every hospital post you do, you'll have someone who's responsible for you overall, and they will feedback at the end of the placement as to whether you've done, well or competently. And the other most important thing is you have to have certain amounts of mandatory training done. So safeguarding of children and adults, very important for GPs. You have to have that done every single year. You also have to have basic life support, although most people have, advanced life support training at this stage, working in hospitals. And you have to make sure these are all up to date every single year. The bit about exams in the corner here, I'll touch on in a little bit later. So it's tailored to a curriculum, the GP training program. And in your final year, you're allocated to a certain practice where you spend the entire year before you fully qualify. Now, the GP training is very good in that it's a 7 to 3 week split. So if you have 5 days in a week and you split them into half days, that's 10 sort of sessions. So 7 of those are clinical and 3 are non-clinical. So that can be sort of private study, doing an audit, doing an ITP day, so a day where you have a specialist interest. For example, if you like dermatology and there's clinics going on, you can go in and watch those or take part in those. And you also have mandatory teaching you must go to, which is normally face-to-face, although during the current pandemic, it's all changed to online. And you have sort of guest speakers and, you do sort of peer group work. It's a really good opportunity, but it's one of the best parts of the training program because you meet your colleagues regularly. You can raise sort of any experiences, reflect on what's gone well. You're allocated 30 days of study leave a year to do this, and you also get expenses to go to sort of training programs if it fits the GP curriculum as well. So this is just the autumn timetable, an example that we're doing here in Brighton. So we did pediatrics from a pediatrician last week. We're going to do musculoskeletal from an orthopedic surgeon next week. We'll then do exam practice. So RCA is a new exam that they've introduced, which I'll talk about a little bit later. You get to go to the hospice to see end-of-life care. And then in Brighton, there's quite a lot of social deprivation, and there's a high amount of homelessness, and that often presents to primary care. So you have a talk from the Housing Association, how we see, deal with these social factors that patients also present with. So I know one of my colleagues is going to do a talk about what's a typical day. I thought I'd just add this in. There's no such thing as a typical day in general practice, and most people do lots of different things. You can do minor operations, you can do a certain number of days a week. But as a trainee in GP, this would be what I was doing in the last few months. I'd go in at 8. I'd review any lab reports, emails I had, and then have a morning surgery. And you start with 30-minute appointments, which is quite long in some cases, but very quickly you move down to 20 minutes. and then 15 minutes, depending on how well you're doing, with the goal being 10-minute appointments, and when you're fully qualified. Each of these are under supervision, which means there's someone sitting there in a room next to you, seeing their own patients, a GP, but they have slots blocked out where they can, you can jump in and ask them a question, they can review a patient with you, which is really good. You're always very supported. You then have a break, you see any urgent patients that have turned up to the surgery in that day, and then you do the same thing again in the afternoon. And then by that point, all the lab reports, all the referrals are coming back, and you review these letters. So that can take up, as a trainee, the timings are more rigid, whereas obviously the GP, you're probably running much past 5 o'clock. Obviously with COVID-19, this has all changed, and as my colleague was speaking earlier, we've moved online. So you now have 50-minute phone appointments, and it's total triage. But in a way that sort of has been quite good. So you can see lots of patients with sort of skin rashes who can do an e-consult, so email in, and they'll do urgent phone extras as well. And then you can see, sometimes you'll speak to a patient and within the first few minutes, you'll know, I just need to see this patient face to face. So example of that is abdominal pain, or just it's very difficult to get a history from the patient, and you think it'd be much easier if I just examine them and I can tell them this is something, nothing to worry about, or this needs to be investigated. You do the same thing in the afternoon, and then at the end of the day, there's always phone slots booked for, there's face-to-face slots booked for urgent appointments. It varies wherever you're working, but more and more we're seeing patients face-to-face. Anyone with fever would go to a hot hub, so they'd only see patients with fevers to keep the practice safe. But you could see anything from, a minimum of 2 up to maybe 10 patients a day in the surgery. It just depends, obviously, what turns up in the day. So once you've sort of completed your 3 years training, during that time, you have to do certain exams to become a member of the Royal College of General Practitioners. So every specialty will have a Royal College, and the GPs have the MRCGP. And it's 3 components. So there's the applied knowledge test, the AKT, which I'm going to sit next January. So it's a multiple choice computer-based assessment. You have to pay to sit it. It's a 3-hour, 10-minute exam. It covers pretty much the entire thing, everything you learnt in medical school, and it's applying that to patients. So when I ask you specifically, this is the question, and what is the best treatment? It's for this particular patient with the information they're given, what would be the best management, and which makes it more difficult. You then ordinarily have the CSA, which you do sometime in your final year. So the written exam you do in your 2nd or 3rd year, and the OSCE, the CSA, you do in your final year, which is a simulated surgery where they'll assess your sort of behavior, your professionalism, and your communication and knowledge. And you have actors who play parts, and you'll go around different stations and be assessed. This has now changed because of COVID-19 for the next 2 years. It'll be called the RCA. So you have to record, live consultations, which is somewhat, a little bit more hard because you don't know what's going to turn up. You don't know which way the consultation will go. It's meant to last 10 minutes, and you have to cover a certain curriculum. And then these are consultations are listened to by examiners, and then they'll either pass you or ask you to retake it. The final thing is the workplace-based assessment, or the e-portfolio. You do this throughout your training, and you have to have a completed e-portfolio by the end of your 3 years to fully qualify. Now it can be a pain, but they've sort of simplified it. They tell you what the minimum requirements are, and as long as you do a little bit of work throughout the year, it's not a huge deal to sort that out. So just to sort of summarize, it's a really flexible program, more so than a lot of training programs. It allows you to pursue academic interests. There are lots of trainees currently who've got experience in pediatrics and medicine who've changed because of the flexibility to primary care. And it allows you to sort of do less than full-time training. If you want to pursue other interests, you can take a year out to study, and they're very supportive of that. And then obviously when you qualify, you're a fully fledged GP, and I think you can do anything you like almost. You can go to work in A&E where there are primary care hubs. You can work for the CCG and see how funding affects services. You can become an academic GP. So there's lots and lots for you to do. So that's the end of my presentation. Obviously, if you have any questions, I'll be happy to take them. But thank you very much.
Hello, everyone. Thank you, Ali, for your thorough explanation. That was really, really helpful. And I've noticed that you presented an e-portfolio, which I believe is a software called 14 Fish, which probably me and Ayede didn't get to see, or maybe Ayede is still...
I didn't do that. No.
We did it the hard way, okay? So
yeah, you guys have it easy.
Remember that. I wanted to ask you a couple of questions, both of you, as a matter of fact. So I'm in a unique position here today, as I've trained in Turkey for my primary medical school, but I did my GP training in Glasgow, so I'm familiar with both systems. So one of the things that I find that we lack in education in Turkey in general is the concept of reflective practice. So I wanted to ask you both, perhaps let's start with Ayede, on what are your thoughts about reflection? Do you see this as something of a burden? Is it necessary, or is it something that you actually found beneficial? Would you argue for it, or would you like to get rid of it?
Thanks, that's a really good question. So reflective practice is very, very good. It's an opportunity to look at what you're doing, what you've done, and how you can do it better. That's the best way I'll put it. So reflective practice was introduced to me as a junior doctor rather than a GP training, because we had to use the portfolio even as foundation doctors. I trained in Hull and East Yorkshire in Northeast England, and we had to go in and put what are your thoughts, what would you have done better, what actions will you take if you were given this opportunity, and what will you do different? And it really helps trainees look at near misses, significant events in a good way, and also it projects further for self-development, because if you look at reflective practice, it's something that can cut across both profession and general life. Like if you're driving and you almost took the wrong drive, be like, what did I do wrong? Was it the other driver? Okay, what will I do better? So if you look at it as a way of life, it's very easy to apply it as a doctor, as a junior doctor, a family doctor, in everything you do. What can you do better? And the way the UK structure works is really good, the way it's incorporated. We have near misses meetings, we have significant event meetings, and these meetings are all centered around reflective practice, where we look at what happened, what could have happened, what can we do better, and what actions are we going to take to make sure that this is what will happen next time. So that's really good. I hope I've been able to explain it in a good way for you.
Thank you. And I'd like to ask you a bit more specific question on this. So obviously we had a big kerfuffle around a famous GMC investigation, which reflective practice and e-portfolio was actually mentioned, that it may be exposing us, admitting our errors, so to speak. So how do you feel about that at the moment? Have you been given any training on mitigating that, or do you feel safe practicing in the UK?
Yeah, so that's a very good question. That was obviously a very famous, very sad case. Initially when that happened, I think there was a lot of confusion from the hype, because you're sort of told as a doctor, you have to learn from your mistakes, you have to learn, be able to improve things. And we were asking the same question as trainees. So, what if we log something and it shows that something didn't go quite right? Can it be used against us? I think the way sort of reflection works is it's less about necessarily this happened and I've made this sort of mistake, but you document more generally about a situation, about an entire case, and then how you can improve things and do better. But in the way medicine is, and in the way it's quite becoming more litigious, it is something to bear in mind. I think it is something that's in the back of the thoughts of a lot of my colleagues as well. As a trainee, obviously, you like to think you're more protected because you're working under a senior, you're working under a consultant, but it's something definitely to be aware of. I think Ayede as a GP would probably say, once you're a GP, as you know as yourself as well, that it's on you. Every decision, there's sort of less, maybe as much teamwork you can obviously ask, but you have to justify the decisions you make. And so I think it can be difficult. But I agree with her in that, you know, reflection overall is a great thing, especially in primary care, because it gets you understand why as a patient, you know, patients present for lots of different reasons, not just the reasons why they're unwell, and it helps you sort of understand that.
Perfect. Thank you guys very much. And on that note, I'll explain a little bit about what's going to happen next. So we have another presentation that explains hopefully the unique role or the ability of the GPs to go into what we call portfolio carriers or special interest or areas outside your perhaps typical day. And unfortunately, Daniel, who was supposed to present that to us, is unable to join us live, but have done a recording which goes on to show us the importance of the technology and how we can be in a place that we're not at and join a live crowd watching us. And after that, we'll reconvene all together and have a little panel-like discussion, basically an informal conversation about the importance of international networks, international collaboration. And I think Professor Akpınar is now going to use Daniel's presentation to inform us on the alternative and portfolio carriers in the GP model in the UK.
Hello, everybody. I'm Professor Dr. Ersin Akpınar, the co-chair of this Congress, and just watching and listening everything on behind the screens. Daniel Crowfoot, Dr. Daniel just sent us his presentation, and I will just share the presentation with you. And we will use the technology as Cemal said, and now I'll just share the screen and the voice also.
Hello, my name is Dr. Daniel Crowfoot, and I will be doing a short presentation on extended roles of the general practitioner. This presentation will cover what a GP with an extended role is and explore what opportunities there are for extended roles as a GP. So what is an extended role? The Royal College of General Practitioners, or RCGP, defines GPs with extended roles as a GP who undertakes a role outside of the scope of GP training and the membership exam for the Royal College, MRCGP. This role requires additional training. This is the new term for what used to be called GPs with special interests. There are many possibilities in developing an extended role as a GP, and a small number of them are listed on the slide. There are many different clinical roles, which may include extended scope practice in dermatology and skin surgery, gynecology, urology, musculoskeletal medicine, and ophthalmology, to name a few. Extended roles can include opportunities for research, such as that conducted in university research departments or the charitable sector. GPs may develop their role in undergraduate or postgraduate education with teaching the doctors of tomorrow, as well as healthcare professionals. There are opportunities to become appraisers, specialise in writing detailed medico-legal reports. GPs may choose to develop an active role in commissioning, such as working in a clinical commissioning group, or CCG, that commissions local healthcare services. Some GPs may consider developing a role in cosmetic medicine. There really is a huge variety of extended roles. So why become a GP with an extended role? The reasons behind becoming a GP with an extended role are varied and dependent on the individual and the role. Extended roles can help add variety into the working week of being a GP, and it can afford the opportunity to develop an area of interest. Extended clinical roles may help reduce waiting times for treatment if it can be done by a GP with an extended role in that area. Secondary care hospital services can then focus their attention and resources where best needed. So what is required as a GP with an extended role? Additional qualifications, such as postgraduate certificates or diplomas, may be required to apply for an extended role position. Whilst this can be self-funded, there are some schemes, such as Health Education GP Fellowship Scheme, that can help contribute towards qualifications or getting experience in the GP's area of interest in which they would like to develop a role. As part of annual appraisal, GPs working in the National Health Service, NHS, are expected to demonstrate that they have maintained competence and are up to date across the scope of all their roles. This is something that they are required to do on an annual basis. With respect to accreditation, dermatology and skin surgery was the first extended role to be included by the Royal College of General Practitioners accreditation process. The RCGP plans to roll out accreditation to further extended roles. The process of the RCGP National Accreditation of GPs with extended roles involves completion of competency-based assessments and other relevant documents. So what about my journey as a GP with an extended role? I became interested in undergraduate medical education whilst taking opportunities to informally teach medical students on my hospital rotations as a GP trainee. I knew that when I qualified, I wanted to try and embrace this as an area of interest. When I completed my GP training and qualified as a GP, I joined the Health Education England GP Fellowship Scheme. This allowed me to work as a GP, as well as explore my area of interest in medical education. The fellowship scheme provided me with funding to work as an associate role at a local university where I was able to have an active role in curriculum development and small group teaching of medical students. The fellowship also funded me to complete a master's in medical education. Using my experience and qualifications, I was then able to apply on the competitive job market and successfully obtained a clinical teaching fellow position at the University of Nottingham. I also work as a community hub tutor. These roles involve me teaching medical students in both the university and also in GP surgeries. And this is in addition to my life working as a GP. So in summary, GPs with extended roles undertake roles that are beyond the scope of GP training. And the MRCGP and additional training is often required to be a GP with extended role. The roles can be providing clinical work and non-clinical work activities. Extended roles can add variety, address a need, develop areas of interest, as well as making a difference. The additional qualifications and experience may be something that has to be self-funded. However, there are funding opportunities out there. I hope you found this talk informative. On this slide is a list of the references I've used for this talk. I would like to take this opportunity to thank you for listening, and also to pass on special thanks to the Vasco da Gama movement team, the RCGP, the University of Nottingham Division of Primary Care, and once more, thank you for listening.
Hello everyone again, and I will extend some offline gratitude to Daniel. So we will email him with a thank you card, and in return of his offline presence as a good example of asynchronous communication in the COVID pandemic world. And now we will move on to a little panel-like informal discussion, a little bit about the importance of international networks. And I want to start with Ayede, and the reason is that she doesn't know perhaps, but we do share a common background. I did serve Junior International Committee for about 4 years as a vice chair and also as a treasurer in the past, and I did try my best to support the Vasco da Gama network. Ayede, could you tell us a little bit about the role of JIC and what compelled you to get involved in such an organization?
Okay, thank you. So I didn't hold any specific post within the JIC actually. I'm just one of them. I'm just a member of the JIC. But the JIC promotes passion for global health and collaboration with other family care networks. Family care medicine, junior doctors and trainees in other European countries, which has been very, very good. If you look at the services they provide, you look at the activities and opportunities they create for collaboration between doctors to be able to go on exchange, to learn about family medicine in other countries, to be able to meet and network with other family doctors. The experience is quite vast, and there's so much. The organization of the JIC is very good. I did speak to the General Secretary not long ago, and obviously because of the COVID, they've kept some stuff on hold, but they are still operating really well at the moment. So the JIC is really good, and we do encourage junior doctors that are starting GP training to get involved with the Junior International Committee, especially those that have passion for global health, because there's so much they can bring. They always welcome different skill sets into the program.
Thank you. So just to recap, the Junior International Committee is a committee of the RCGP, so the Royal College of GPs, and it's exclusively formed of a special group of GPs, which is called First Fives, which is GPs who have graduated and they're within the first 5 years of their professional career, and GP trainees who are going through their training at that moment. And they work, as I had said, on global health. They arrange exchanges, and they're the arm, they represent Vasco da Gama within the Wonka Europe context. And Ali, don't you think we have enough problems in our own countries that we are trying to collaborate internationally? Don't you have enough on your plate to do your e-portfolio? Why do you bother with this international collaboration business?
True, but I think it's international collaboration is such a great thing. You learn. Medicine's all about learning, isn't it? And learning from experiences. In the world is becoming more and more globalized. People are traveling more. Places where there was not much diversity maybe 20 years ago, there's huge amounts of cultural and ethnic diversity, and that all impacts on medicine. And what international collaboration does is it allows you to learn from people who work differently, work in different settings and different cultures, different experiences, and bring that into your own practice and to your patients as well.
Fantastic. Yeah, I absolutely agree. So I was trying to take the position of the devil's advocate. Sometimes we do get from our trainers and superiors, I must say. Professor Akpınar, I want to ask you, as an international academic, I kind of know your CV. I've seen it, and I know that you've been around. You've traveled a bit in the world. From an academic perspective, what should the trainees or perhaps the junior doctors of today should aspire to academically, what would your advice be to network internationally, to go out? Because it's a scary process sometimes.
Yeah, thank you, Jamal. First of all, for the experienced faculty, my advice is just firstly to young doctors to join those kind of and this kind of meetings, so we can meet and explain our CV or experiences or subjects that we are interested, so we can share lots of things. Before this session, I have no idea about Ali or Ayede. Now I recognize everything, and maybe after this session we will just have some email connections. Maybe we invite them to our clinics. So this is the first step, and then after face-to-face recognition, I mean, the introduction, after the introduction, we can just share our experiences and then connect and collaborate to have the researches or help to us or each of us to explain our problems and solve problems. It's like a family, you know, we are the family medicine physicians, you know, family physicians. So it's like a family. The first step is just the introduction, yeah. And we just, the first step is the difficult one, and then you succeed this one, I think. Thank you for the Vasco da Gama team and also the UK team.
Okay.
Thank you, Professor. So I want to ask a general question about this. So when we are, originally this meeting of course was planned as an exchange, and we were all supposed to be there, meeting in person and learning the practices, but that opportunity for a while is taken away from us. It's open question, whoever who wants can pick it up. Do you think this new technologies that now we're adopting, is it gonna make collaborations easier, international networking easier, or is it gonna take away the human element, and it's just gonna be within this hour and then the communication will stop?
My idea is this starts something that if you don't have the face-to-face interaction, and we cannot come to a final decisions or final project. So this is the starting point with the technology. But without coming together, as I'm from the eastern part, so we are just willing to have face-to-face dialogues. If we want to make some collaboration and researches, we need to come together, drink coffees, you know, eat something, and explain lots of things. So this is the first step, and then technology starts this. But probably after this COVID pandemics, we will need to come together.
Thank you. And Ali, do you have any addition to that?
Yeah, I think I totally agree. I think it's a great first step, the technology, especially for, you know, I know the effort gone into, you know, reorganize this and put it online, and for it to go ahead is, you know, a really great thing. I think in an ideal world, you know, face to face would be great, because you can, you know, as a human element is, as family physicians, what we do general practice sort of for. But in terms of, you know, opportunities, I think we found ways to adapt in the past 6 months that, you know, would ordinarily take us 5 or 10 years to do. So I think that's a great thing, that we can still do these sorts of conferences, have these meetings, and learn from them and go forward.
Thank you, Ali. That's a very valid point there. And Ayede, what do you have to add?
Yeah, I agree with both of them. They have positive to the use of technology, like what we're doing now, how we're able to interact from different countries and have the.
Have we lost Ayede?
Lost, yeah, Ayede is just lost.
Oh, okay. Maybe laptop can have. So, well, I'd like to put my tuppence there as well. So I think I see this as an opportunity rather than a barrier, to be honest. Now we don't have to travel anymore, and you may think of it as a green exchange. So to meet my colleagues in Turkey, to meet my colleagues in Bangladesh or Australia, all I need to do is to launch a web browser, and immediately we are live connecting. We didn't realize the importance of it as much, perhaps. And I want to reiterate how deeply actually we are being involved in our lives at the moment. So we're not just having a Zoom meeting. At the moment, we are looking inside the flat of Ali, probably, or we're looking inside the flat. Like we're at my flat, and I want to introduce you to my dog, so you can have this kind of very personal interaction. So he's called Theodore. So, so we can have this very personal interactions as well. So I think we have to use it as an opportunity, and I think Ali suggested nicely that we need to adapt and we need to be a bit flexible about this sort of processes. And once again, I'll ask actually I wanted to ask Ayede about her experience, but if she joins us, we'll do. If she doesn't, then we will conclude. Could you tell us a little bit about Professor Akpınar around the available European or worldwide networks that that you know of, that you can suggest for us to look at, which ones you found helpful in your practice, and some guidance towards that?
Is it just for the network in Turkey or across Europe? Which one you want me?
International, if possible.
International, yeah. The international way to connect or having a network just starts with those congresses and conferences. Because if you want to start something with online, you can start it, but to personal touches, personal connections is the way to just promote the projects and then make it bigger. So we get the network, lots of participants or the groups. So I just advise the young doctors to join the networks of the congresses, introduce themselves, and then we are so open and we are just willing to overcome the problems or give the solutions about going on the project. So we just need to have the connections with the young doctors. I don't know, for example, Ali, what he is doing, or what's his interest. But after this, he may say, I'm just working with this group, for example, in the COP groups or hypertension groups. And I say, okay, we have some academics here, or I'm just having the project like that. So we need to introduce ourselves, first of all, and then give some interest on making the network. Without the networks, we are nothing, yeah.
Thank you, Professor Akpınar. And Ali, on that note, are you a member of any other international organization? Are you having being involved in any other networks? What's your level of interest as a trainee doctor?
Well, as a trainee, sort of, I'm just like getting to come to this conference. Sort of, I think it's about taking that sort of step. So currently, not sort of any networks, but in the last year, I've been looking at what I'd like to do when I'm sort of qualified in the future, what if I want to have a specialist area of interest in sort of public health and that sort of type thing. And then sort of emailing, I found it quite, if you just go online and you find, most people in medicine are quite friendly, and doctors are willing to speak to their younger colleagues. So you just email them and tell, I like what you do and I'm interested in this. And I found that to be quite an easy way. People be like, oh, let's have a meeting, let's have a coffee, and we'll talk about where we can get you interested in. But I'll certainly be looking forward to joining certain groups and seeing what's out there.
Yeah, it's very important to be looking for opportunities as well. I mean, and I must reiterate, perhaps to my junior colleagues, is that it doesn't just happen. You don't get involved in organization just by sitting in your bedroom. You have to be a bit curious. You have to do a little Google search, ask a few people, and I can certainly say that you have to put a little bit of effort in it in the beginning to get involved. But after that, every connection is a bit like the virus. Every connection connects you to an R value of over 2, I guess. By that, you can expand your network very fast, very rapidly. And I'm wondering if Ayede is going to be able to join us. Perhaps
she is just trying to join us, but she couldn't. So we might just move on, maybe without her.
Then I'll ask the heart. I was going to ask her the heart.
Yeah, now I think she is ready, and then I will just add her. Okay. Yeah, she's coming and connecting with the videos. Yeah. Ayede, do you hear us? Yeah. Yeah.
Welcome back, Ayede.
Sorry, connection issues.
Okay, no problem.
It happens in the UK as well, so it's not problems all around the world. Ayede, so we were talking about international collaborations, and obviously I'm going to have to ask you the hard question, that what can we do to mitigate the Brexit effects? So now we've left Europe, we've publicly said we don't want to perhaps collaborate as much, and in the international view of the Brexit have been a bit challenging. So what can we do to mitigate that effect by our international collaboration, international networks? Do you think it's going to impact the UK's ability to lead the way, or at least be a uniting force internationally?
I think international collaborations are really good. Can you hear me? Sorry, it's echoing.
Yeah. You just open two.
I think I'm in two screens at the moment.
Yeah, 2 screens. Yeah. You are in 2 screens.
All right, I'm gonna leave one.
Okay. That's fine. Yeah.
And if you could unmute the microphone of that.
I'll try again. Okay. Yeah, that's okay.
Yeah. I think international collaborations are very important. Like we've all mentioned, for global health, for connection, for interaction, for co-elevation of ourselves as doctors, trainees, and we can share knowledge and share other stuff. So I think it's really good. The VdGM upcoming conference is going to be in the UK next year. So I think UK is leading in that direction in form of bringing people together. And we are discussing here about promoting the activities of GIC and the VdGM a bit more, because I found that some trainees yet don't know about it. So we're trying to promote it a bit more in this area. But I think it's very important, and I think UK is doing it. And yeah, I hope that answers the question.
Thank you. From my personal experience, I can say that having been involved in multiple international organizations now, that at the core of everything, I think all the problems that we face in their core are the same. How do we bring value to our consultations? How do we bring value to our patients? How do we create a just system? How do we create an equitable system that serves everyone? And I think it's at the heart of the medicine, and international collaboration is a way to push for this, to push for the policymakers to become stronger and to become more streamlined in our message to our politicians, to our leaders, in order to create this sort of opportunities and abilities to achieve a better world in the end. So on that note, I think Professor Akbunar, do you have anything else to add? I'll go for a little round to get some final remarks, and then if everyone's happy, then we'll call it a day.
Yeah, I think the difficult part for the young doctors is just to start a new thing, or the project or the collaboration. After starting a new project, they just move better than us. They are so willingly to move a project or develop a project. So the difficult part is just to start it. So as we are an experienced academic, so we just need to help on the moving part. After that, starting, we believe to young doctors, they are better than us, and then they just see the lots of views better than us in this technological years. Everything is changed. So we are like dinosaurs. We just need to move them a little bit more, just in the starting part.
Thank you, Dr. Akbunar. Ali, any final remarks from you?
Yeah, I'd say as a young doctor, and you peer away from sort of completing training. I think like this, the opportunities are out there, and you have to do a bit of work. You have to look and find them, but they are definitely there. And people, there's a whole scope, especially in primary care. There's a whole variety. If you have an idea, I think, and you think it's, if you want to hear it, there's always space for someone to listen to that idea and to take it forward. So I just encourage people to look, email, search, and get involved in things.
Yeah, don't be afraid to ask, right?
Definitely.
Fantastic. And Ayede, final remarks from you? Thank you.
Like Ali said, there's vast opportunities in primary care and family medicine. I always encourage people to go into family medicine. There's vast opportunity in getting involved with the vascular Gama movement. If you're thinking, I'm just hearing about this now, should I do it? I think you should. There's vast opportunity in getting involved in international and bigger committees and organizations within your country, family care, so that you can build it up and even go further and be that vehicle of change for family medicine, for global health pronouncement, for collaboration. And there's so many things you can do, and I just encourage everyone to go for it. Go for opportunities. Sometimes it's not going to come to you very easily. You have to ask the questions. So don't be afraid to send an email, to connect with someone that is doing something you like, to just have a conversation. It's very simple, one line. Oh, you're doing this, I'd like to know a bit more. So I'll encourage everyone to be proactive and to be audacious and go for it. Okay.
Thank you very much. On that note, friends and faculty, it was a really, really good session, and I hope that you benefited from it and had the opportunity to learn about primary care and GP training and the extended roles of the GPs in the UK. And it was really nice sharing ideas within this group about the importance or the necessity or the must of international collaboration. I wish you a great day and the rest of the conference, and hope to see you face to face with non-social distanced areas soon.
Yeah, thanks so much. Yeah.
Thank you. Thank you.
Thank you. You're welcome.
Thank you.